Welcome back to another episode of Healthspan Horizons. I am so excited to be back today with my co-host Jasmine, with our very special guest today, Dr. Andrea Maier. Thank you. Welcome for being on here today.
Thank you for having me.
Well, most of our guests on here, not guests, most of the people watching are longevity experts and such, but some of them may not know who you are. I would love if you could quickly intro yourself, talk about the cool things that you do. We'll get more into specifics, but would love for the highlights.
Very short, I'm Andrea Maier. I'm an internal medicine specialist and geriatrician by training. I try to revolutionize the healthcare system while introducing healthy longevity medicine, which is also now coined precision geromedicine, into clinical practice. And what is that? That's optimizing health while antagonizing the aging processes across the lifespan. So that's what I do. I'm a clinician, I'm a scientist, I combine it, and I'm an entrepreneur.
Awesome. And yeah, I mean the paper that recently came out about geromedicine, that's incredible that finally, these kind of terms are making its way into the mainstream. And so I guess we can maybe, start there about, you've described aging as the most important risk factor for chronic disease, and, how close are we to actually treating aging and targeting it as an actual clinical condition versus just kind of the classical approach of going after disease by disease? And how do you see this landscape kind of evolving?
Yeah, that's so many questions in one. Let's disentangle that a little bit. I'm a clinician. I am a geriatrician, which means that I am seeing individuals at the age of 80 or 90 who come with full potential, and then we have to disentangle what their potential is and what we can actually reserve and reverse in terms of the aging process. What we learned in the past 3 decades, I would say, is that aging is nothing else than the accumulation of damage. And while accumulating that damage, we could actually intervene. We could maintain the health. We could provide services or interventions which make somebody younger. So in the end, I realized 2 decades ago that geriatrics is nothing else than the accumulation of damage. And it might be much, much more better if I would see individuals earlier in their life, because why should I wait until all the age-related diseases occurred? And that led, while having lots of debates and lots of papers, towards the coining of the term precision geromedicine. And what that actually is recognizing the aging process as itself as a driver of age-related diseases, that we could prevent age-related diseases and the accumulation of it. So why would we actually not bring that into clinical practice? And that led first to the term healthy longevity medicine, healthy longevity as the outcome, the goal of the medicine. And because of lots of criticism of the term, what is healthy longevity? It's not being defined medicine. We get what it is. Precision medicine is a term being hugely used at this moment in time, really realizing that you and I, we are very, very different, and that we need a precise approach towards health. We coined the term precision geromedicine, and that's what we are describing with Guido Krömer in the Cell paper, which was published a couple of months ago in April 2025. What we are describing there is really the new arena of how we could change the healthcare system, give them arguments why we should do that, describing what geroscience is, because that's the building block of what we do, and describing the new speciality on top of that, and also give advice what kind of new trial designs we need to showcase that what we propose is actually clinically effective and cost effective.
I'm so excited to be talking about this with you today. I feel like there's so much potential, and even just some of the new and reoccurring interventions that you just mentioned. So tell me, what do you feel like with all of your research and such, what do you feel like is the most promising intervention that you've come across right now?
Maybe I disappoint you, but I am not. Yes. Very often we are jumping into interventions. I can tell you, if we have no diagnosis, you cannot intervene, and you should not intervene. The entire healthcare system is based on first making sure that we know what we are intervening, So we need a sort of disease, we need classifications, we need something measurable. And once we have that, we can then attack in a precision approach that problem with the right intervention. So before, we are so enthusiastic, and of course I'm also enthusiastic about interventions. We need first disentangle why somebody is aging, how somebody is aging. So not only what the pace of aging is, but where the aging is more massively occurring compared to other locations in the body, and why. This is most important for me, why somebody is aging. So to get a little bit of take a step back, 10 years ago, the first clock was introduced. These were epigenetic clocks by Steve Howard, and also a clock based on other lab parameters. Since then, we are judging, or could judge, diagnose individuals based on their biological age, the biological age compared to the chronological age. That was the first paper, like 10 years ago, describing that we could measure a biological age. Now we know that it's not only the pace of aging, which is different, but also our organ systems within our body are aging differently. And why we are aging intrinsically might also be different. So first we have the pace, where, and why. And based on that, you can actually pair it with an intervention. To make it even more explicit, 60 years ago, when, for example, women were diagnosed with breast cancer, we only had one or two different interventions. We just would throw it towards these women. It's getting rid of the breast, getting one chemotherapy, or giving the entire load of radiation. And that's it. Nowadays, we actually take a biopsy. We are looking at what kind of cells are differentiated, what kind of tumor it is. And we have a plethora of interventions. So we are basing that intervention based on the diagnosis of a certain disease, such as breast cancer, colon cancer, even heart failure. So the same applies for the aging trajectory, aging as a disease, if you want. First, we have to analyze what the ageotype is, so how somebody is aging in terms of pace, in terms of where and why, and then we have that intervention.
That was a much better response, I feel like. I know. No, I feel like that was a much better response to my question, because it 1000% makes sense. I mean, we talk about it in our field as like N of 1 trials, where basically you're testing what works best for you, because what works for you does not work for me or for Jasmine. And what you're talking about is so important in that aspect of it. So I agree, even though I was hoping you'd be like, oh, I really like this one. I understand your sentiments. So,
okay.
Jasmine, I feel like I'm cutting you off. So.
In the NS1 approach, also there, it's very important that we can first measure. We determine the outcome of that individual, then do the intervention, test what the outcome is, to then be able to not even switch, but maybe also titrate the dosage of that intervention, the frequency of the intervention, the duration of the intervention. And maybe then if we see, okay, it does not work, or maybe it works, but not as effective as you thought, then we are switching or we are adding something. But understanding first the biology behind it is so important. And that leaves me, I think, with the only conclusion, and I think the myth in the entire field, that longevity interventions can never be a la carte. So you as a consumer, maybe you can because you have the knowledge, but it should not be as in a restaurant. I'm going into a restaurant and I say, I want a pizza margarita. And then I'm getting the pizza margarita. That's not how longevity services should work. It's not that you are going into a sort of longevity clinic or shop and say, I want an NED infusion. Like, stop it. That's not what we actually should do.
Yeah, that's super important, kind of getting that the context and analysis, along with the understanding. And I want to get more into the kind of lack of women representation in longevity research in a bit, but I guess maybe we can just kind of go a little bit back to the idea of there being differing viewpoints about longevity interventions and even the definition of aging, as you kind of mentioned earlier. So, how important is it to facilitate the scientific consensus on, things like the definition and what type of interventions that we should be going about, and in what means and ways to kind of measure them? And I guess maybe that gets a little bit into biomarkers tracking as well.
Yeah, so first of all, many people think that I'm criticizing the field. It's absolutely not. But what I very often do is saying, hey, here is a gap. So I'm hugely proud of the field, because what we established in the last 10 years is that we came to the conclusions that, as in other medical specialties, we should group together and we should find a consensus for example, what is a biomarker of aging? How do we test things? What kind of interventions should we do? So what you see, especially in the last 3 years, is a huge, it could be an evolution, but also revolution. I think the revolution is better, to see how we can come to a consensus to define the field better. And that's very important. So you touched on a couple of terminologies. What is a biomarker of aging? We now have the Biomarker of Aging Consortium, which is led beautifully, where you really see that young investigators, a little bit worse, more senior investigators, or the dinosaurs, are working together and really defining now each of the terms, that if we are writing a paper or we are discussing with the FDA to approve a certain biomarker, that everybody should know what that means. And that's very important. We also define not only what a biomarker of aging is, but the different subcategories, that we can actually make sure that if we are talking about a responsive biomarker of aging, that everybody knows what we are talking about. At least there's now a terminology and a sort of dictionary that we can refer to. The same we did partly with precision geromedicine. We wrote a paper about the vocabulary, the gero vocabulary. So what is a gerodiagnostic? What is a gerotherapeutic? What is geromedicine? To define that. And I think that's the basis. What is still lacking, I would say, and which is the most fundamental part, is that we don't have a good consensus yet what aging is. And I think that's so fundamental, that we define in a big group, and we can define it roughly and more generally, but we should define what aging is. Because if we say that aging is the sort of root cause of age-related diseases, we have to be able to say what it is. So that is missing. I know there are a couple of papers, but there's not the real understanding what that is. So with the Academy for Health and Lifespan Research, we really now try to get that aligned. So hopefully next year we will have a definition. So for me personally, we need definitions, because otherwise I cannot work. I cannot even think about international classification of diseases, because every word in a classification needs to be defined.
Yeah, for sure. I mean, it will be interesting if, or monumental if the field can kind of agree on a definition. But I know that there's, still a small faction that still kind of is proclaiming of like the programmed aging approach, and these different viewpoints are that we really can't define it. So, but I think having that definition, is definitely important, especially if we're going to make it a pillar of a clinical kind of target. So maybe you can get into your longevity clinic in Singapore, and kind of how that got going, and what is your approach, to kind of like scaling this longevity medicine as a practice?
Yeah, good question. Thank you so much for this. So I have two approaches. I grew up in the public sector, so I'm a clinician-scientist, and grew up in Europe, where academics and doing research and care are always melting together. So while being on wards, you would do research, etc. That's a little bit different in other countries. So I founded a longevity clinic with a public hospital here, an Alexandra Hospital, 2 years ago, the first healthy longevity medicine clinic in a publicly funded hospital. So quite proud of it that Singapore really was the first to establish services for the broader population. However, while seeing how this was emerging, and maybe also seeing that maybe even in Singapore there was not the capacity to enlarge it rapidly, I also founded a private longevity clinic, so Chi Longevity. So we are expanding. We have the second clinic in the Four Seasons. And what I'm doing there is really applying the most important gerodiagnostics with the best evidence. And the evidence-based therapeutics, the gerodiagnostics and gerotherapeutics, to individuals who are aging. So why did I do that? I really jumped as an academic clinician-scientist into the water to be private, because I saw that much more is possible in a shorter period of time, and I love it to actually see how patients can improve and how beautiful the recovery is in terms of biological age reduction of middle-aged individuals.
Okay, so this was not one of our questions, but I'm curious as you've talked about it. So when within these clinics and decreasing biological age, what type of services are you implementing with them to see such results that you're seeing right now?
So if you are looking at the possibilities, what we can measure at this moment in time in Chi Longevity, we implemented nearly all of them where we actually have grip and we know that these markers are valid, which means they need to be reproducible, etc. So we are doing the full range of biological biomarkers of aging, clinical and digital biomarkers of aging. And we created our own platforms and electronic medical records to really be able to merge all of them together to get the better picture of the aging trajectory and the age types of our clients or patients. So from a whole body genome scan to epigenetics to the microbiome analysis to all the lab values, which are clinically important to measure with the right timing. Think about hormonal stages of women have the right timing, because otherwise it's useless to measure, together with clinical characteristics. So from a VO2 max to lung function, to the entire muscle function, to cognitive functions, to double tasking. So very often we forget, using clinical biomarkers of aging, that we should actually combine and stress the system a little bit to see what the value is of and the health of certain organ systems. So lots what we are doing is stressing the body and looking at the results in double tasks, not only for the brain, but also for the heart and for the muscle. And then we are combining all these data with digital phenotypes of individuals, which means that all our clients wear wearable devices. We have the opportunity to have access to this data continuously in real time. So not only for glucose measuring, for example, while applying CGMs, continuous glucose monitoring systems, but also the variables like Garmin, all smartwatches and smart rings. So which means that we can, all our clinician and health coaches can identify what people are doing, what they are eating, and then modify a nudge based on the results. We are giving a plethora of interventions, all which should be proven in humans, at least in a phase 2A to B trial. And with that, we have huge successes. And very importantly is we do not have any patient where we do not measure the outcome. So it's not an a la carte system. We provide, once we have the diagnostics done, we have the reveal, we say, okay, this is the intervention and this is how we are measuring the impact of that intervention. and then adjust during the journey of biological age reduction.
I like that. So it's a very holistic approach, and you actually did, kind of look into it, and saw that you kind of had to sign up for this whole journey, and it's not just okay. Yeah, I can just pop in for this therapy and then just kind of disappear off the map, and you have to, kind of get on this whole program. And so I'm wondering, do you implement currently any AI solutions, and what is your outlook on how that's going to accelerate, the precision of these protocols and learning more about aging and biology in general?
Sure. Very important to be up to date with potential for the field. So AI, machine learning is absolutely at the forefront. We already use AI, I think, as one of the earliest clinics. Of course, we have so many data. If you're looking just at the genome, the epigenome, the microbiome, how do you merge them together to make sense out of it, together with the habits of individuals? So we are using the new platform. Disclaimer, I'm the Chief Medical Officer of NU. So this is a digital platform where we are building digital twins based on an AI technology to make sense out of the biological, but now also clinical and digital phenotype of individuals, to then not only see what and why somebody is aging, but also give interventions and recommendations of it. So yes, AI is super important. Of course, you will not imagine how big our data sets are. But very importantly is it has to make clinical sense. So this is also a little bit a warning for the entire medical system. Very often I hear, oh, I now also do longevity. So what is the training? What is the education around it? They say, okay, I have an AI tool and they will guide me. Like, this is dangerous because data in, data out, bad quality in, bad quality out, maybe good quality in, good quality out. That's fine. But I think it has to make clinical sense, and it should only be applied in, I would say, services with the right education and the right duration of already seeing clients, because otherwise it can be quite detrimental for our field.
I would agree. I think that it's such a, like, even longevity now is such a buzzword, when so is AI, where you just slap that on something and it's like, oh yeah, I got this. So I agree with the sentiments, even though obviously we work in AI, and so I'm like, that makes sense on both sides. So with
Sure.
that, I guess I wanted to chat a little bit more about your thoughts on healthcare and or longevity clinics and such in Singapore versus other parts of the world. Obviously, you are not native to Singapore, so how does it compare? Is it better? Is healthcare better there? Is it more incentivized to live healthier, or what's your experience been?
I would say healthcare is as good as the government structures the healthcare system is, and as good as the behavior of the population. And I think both of them, the behavior and the understanding, there was the knowledge of the population together with structures, is very important. So I'm very lucky and very grateful to live and work in Singapore, because the Singapore government is very proactive in terms of preventing age-related diseases, very proactive to new innovations. And I think that fits the agenda of precision geromedicine. Singapore, I wouldn't say it has a problem, but there's a recognition that Singaporeans live quite long, very long. If you're comparing it to Switzerland and Japan, we always are the best in terms of longevity, in terms of lifespan, 84, 85, 5 years. And the fertility rate is quite low in Singapore, which means that the government really understands to invest in the health of aging individuals, and especially in middle-aged individuals. Because otherwise, who should run the country? We don't have manpower, and we have, I would say, one limitation, and that we don't have land. We are living in a country on an island of 40 by 20 roughly kilometers. So it's quite immense, the issue. So the healthcare system is very, very good. If you're looking at the university structures, it's like superb. And there was also the care and the guidelines, the regulations, and together with the notion of innovation, the notion of urgency to change the not per se healthcare, but the health of individuals, and there with the healthcare system is of utmost importance. So Singapore is absolutely at the lead, not only from an academic and a research perspective, but especially in terms of regulations, in terms of discussions about changes in structure compared to other countries. I think the Middle East is also very innovative, especially if you're looking at the UAE or also KSA, like the incentive to already see health improving for the next generation, so the ones who are now 20 or 30, and then watching what the population could look like at the age of 50, 60, 70 is, I think, of fabulous in the Middle East.
Oh man, we got that awkward silence here. Jasmine, I was going to let you talk, but if you want me to go, I feel like I've talked a lot, so go for it.
I didn't want to interrupt.
No, yeah, that's thanks for the perspectives. And so I guess back on the subject, as you mentioned, kind of hormones can play a role in kind of measuring the aging trajectory, and we know that women have been historically underrepresented in clinical trials and medical research. So how does this affect understanding of female aging, and how are you seeing this demographics play out within your clinics? Like, are you getting a good 50-50 spread there?
Yes, so women's health is hugely important. There is a disclaimer also here. I forgot that there is a gender, like in my entire research career until 5 years ago. I always thought, yes, of course we have females and males, but if you're looking at all the cohort studies, all the randomized controlled trials, I often forgot or always forgot, hey, there's something like menopause. There's really a change in females. So, but luckily, not only I had a little bit of blinded eyes. So I changed that. I absolutely got it, that we should invest in health of individuals who are aging differently. So I do not want to exclude males because they are also very often excluded. If you're looking and having discussions with my colleagues in internal medicine, and I would ask, did you measure the testosterone level of your diabetics at the age of 40 or so? So what are you talking about? So I think there is an entire shift in the mindset that we should use the term holistic, but more general about how organs are interfacing each other and interacting with each other. So there we should absolutely have a focus on gender differences and how not only how they present their symptoms, but also what's underneath. That led to a sort of change in my approach and research, that we now, in every randomized control trial and every observational study based on the age, have the age appropriate questions. So we always ask about menopause. We very often do gynecological assessments, etc. So there is a full integration, I would say, now in all our research in terms of gender differences. I can just tell you that was not an easy integration because I learned that we had no guidelines how to have that gender approach in randomized controlled trials of middle-aged individuals. Of course, how do you measure the health of a 50-year-old woman? What kind of questionnaires do you apply? So that led to an article which is now under review, that we actually describe what kind of test we should do, what kind of test when we should do it, and what kind of questionnaires or digital biomarkers we should assess, which are sensitive actually for clinical change and which make just sense to implement into research. So that in parallel also led to absolutely changing my clinical practice. and really learning, because now I have the tools to also integrate that into my internal medicine practice. So next to being a geriatrician, since 15 years, I have longevity clients, and I optimize their health, but not calling it a longevity or a health longevity medicine clinic. So all my patients from the age of 20, 30, we are looking at hormonal changes, because most importantly is to understand the trajectory of aging individuals. So looking at hormones, and I'm not only talking about testosterone and estrogens, but is understanding what kind of trajectory and most of the time decline is that organ actually showing us. So that's a reason why already at very young ages, we are starting to map the trajectory to learn to then intervene later in life. But having the data is, I think, of utmost importance. And unluckily, I do not know my organ systems from 20 years ago. So I always advise individuals, independent of your age, start early to map yourself, to have and to create your dashboard.
So that
I
really
agree.
gets
I mean,
into, I guess,
go for it. You're good.
yeah, like the baseline aspect of it, and kind of getting into the subject of how important is this kind of early prevention versus intervention, more in midlife, when people actually do start to think about how they're aging, and whether or not they're going to start to develop chronic health conditions and whatnot. So what is your view there? I guess you're kind of suggesting that it's never too early to really start on that journey, and how much of an impact does starting early have versus starting, at 40s or 50s.
So it's never too late. We have patients at the age of 80 to 90 or 100. So it's never too late. That's most important. There's no ageism in health longevity medicine, but it's never too early. We do not give advice at the moment to children. That's really the next step, because we really have to learn from longitudinal studies first for children. But I think the window of opportunity at the age of 20 to 30 is to observe where you are, to see if you really are at the peak of your potential performance. And the performance somebody has at the age of 20 to 30 doesn't mean that this is optimal. Because we always say at the age of 20 to 30, you are optimal. That's not true. Like I know very sedentary 20 to 30-year-olds, which are absolutely not at their peak performance. Maybe that's their peak performance to then decline even more rapidly. But what we really do is making the distinguishment of what is normal and what is optimal and what could be optimal for you. And we learned that from sports medicine, for example, when you are seeing how football players or tennis players, it doesn't matter, how they are being trained is to have that peak performance at the Olympic Games or at an important match. And it doesn't mean that you can maintain that peak performance for a long time, but you know what the peak performance could be. So you have to then discuss with yourself and, of course, with the clinical team to say, okay, what is the performance which is optimal for me, which I can actually maintain, which is not detrimental, because running a marathon every day, absolutely detrimental for your health. I might even think that one marathon is already a huge disaster for all muscles, but that's another question. I think defining what is optimal for that person, where's a good starting point, and then intervening while having a relationship to what you would like to achieve. That's most important. And because of your genetic makeup, of your psychology, your optimal range might be very different compared to mine. So in analyzing it, and that's the reason why we are doing the plethora, everything in terms of diagnostics, including the psychology. What do you want? How do you respond to change mentally is important. So intervention only if you really know what you want to achieve, and to really know what you can achieve is start early in diagnosing and testing yourself at the age of 20 to 30. That's most ideal.
I mean, I wish I was still in the 20 to 30 category, but I would agree with you on your point of just because you're that age doesn't mean that you are peak, because I feel more in tune with what I am, what works best for me now at 35 than I definitely did at 25, because at that point I was still doing whatever I was doing. But I think I agree with you. I think it's so important to just at least have that baseline of like, even I love strength training, of even being like, oh, this is how much you can bicep curl or deadlift, and then seeing the progression and making sure that it's optimized for the future, I think is so important, especially for women, but important for all of us to be able to know. Because if you don't have the data, then you don't know how anything can change or is changing, to be honest. So,
yeah. But also at the age of 40, 50, does not matter. We can actually see what the potential is to increase. But for me, it works best to define that and to work towards something. And also from a psychological aspect, that's very important, because then you have a goal. And Melissa, you might see now, okay, I'm now different and I can adapt differently at the age of 35 compared to 25. Maybe not because you have more biological potential, because there's 10 years of decline in there. But I think you now know how to actually do it and how to react to certain changes. So there's a huge mental capacity and psychological, I think, input in there. And that's the reason why the first person I hired for the longevity clinic is actually a psychologist, to understand the personality of individuals. Because I need to know what the goal is of individuals, if they're a little bit more a narcissist or a little bit more depressed, etc., to also see how to work with individuals on their goals.
That's like interesting. It also ties into the idea of biological age, because you mentioned, like, for instance, there can be, a 20 or 25-year-old that's like, super overweight and sedentary and in really poor health. And then you can have a really healthy 60-year-old that's like super fit and, has amazing biomarkers. And it is perhaps like possible that this person that's older is actually in a better peak condition than someone that's younger. So what does that mean about when we tell someone your biological age is such and such, and how can we refine that and improve that communication to people who are new to the concept?
Yeah, very good question. So let's start a little bit at the fundamentals. We have zero understanding how to tell people how old biologically they are. So we often say, hey, you are 5 years younger, you are 5 years older, but we have zero understanding of what that means to people and if they understand what I say. I think what we try to achieve in the field is now, while talking about biological age, to give it a unit. And the unit is years. And we think and assume that people understand, if I say you are 5 years younger, that what that means. But we have no understanding. So we are very proud in Europe at the Free University where I also work. We just got a grant of roughly 6.5 million euros to exactly understand how we should not only determine the biological age, but especially speak about a biological age with the public. Because we need to know what they perceive. Because think about that, if you would be 20 years older, is it actually ethical that I am going to tell you? It's a little bit like a diagnosis of, now I'm telling you have cancer. We need, after treatment, of after diagnosis, we need services. And we don't have the structure within our field yet. So we are doing now lots of studies with psychologists to understand what people perceive if we are giving a biological age and the concept around that. So that's very important. However, people understand the concept that there is a biological age compared to a chronological age. We did first a nationwide survey in Singapore, but then a worldwide survey, and it's called HELO. to get a better understanding of the knowledge of health span, lifespan, biological age, and if individuals would love to come to a longevity clinic, if they understand the concept. And we found that roughly 2/3 of the population understand the concept of biological age. They know what health span is and lifespan is. And 2/3 of the population, at least in Singapore, understand the concept of a healthy longevity medicine clinic and would come if it would be available for them to such a clinic. And half of them would also pay for it. So we now have that understanding. But still, we do not know how to actually verbalize that. And that's so important to now do further research to not harm individuals, but because of diagnosing something, that they actually understand what we mean. And it's not only the public, so there was the patients, but it's also the healthcare professionals. What does a GP actually think if I write in my letters conclusion, the biological age of the heart because of proteostasis problem is 5 years older? Do they understand what I mean?
I feel like biological age is like a real double-edged sword, to be honest, because that's a number that might make people take action, but at the same time, like you said, it's like well, is that actually hindering or helping you? To be determined. We are almost out of time, actually, so I just have two hypothetical questions or your own personal opinion questions left for you. So my first one is, if you could see any, I'm going to call them longevity interventions. If you could see anything fast-tracked within the field, what would you want it to be?
I would love to see multimodal interventions. So we have lots of evidence of one intervention in humans, but we don't have the double up or the triple up or the quadruple up. So, and we need to know what works best if you add something and what maybe not. So where do we have a double effect and where do we actually reduce the effect? And that needs to happen, in my view, in the next coming 3 years. A second, so that can be nutraceuticals in combination, that can be repurposed drugs. So that's important. Another fast track we really need is a sort of ITP program for humans. So you might be aware of the ITP program in mice being financed by the NIH and the NIA, where individuals or clinicians, scientists are testing repurposed drugs or nutraceuticals on mice in a very standardized way. So we need that for humans. So we need programs in phase 2B and even phase 3 where we either in one country or globally test repurposed drugs. So we are waiting for the TAME since 10, 15 years now. I think we really have to get our act together and build the huge consortia or meaningful trials to test repurposed drugs. Because they're already there. We have many off-label interventions at the moment as an NS1 approach. Why can't we bring that to a different level? And related to that, we really need registries because many longevity clinics are there on Earth. Let's define what we should measure, how we should measure it. Let's put it in a database that on global level, we actually know what works and not works out of the information which could be readily available. So it is really the multimodal ones. It's the bigger trials on repurposed drugs, and it's a registry. And because the registry, it's happening, not the registry is happening, but the clinical care is happening. So using that information would be wonderful. Why not using all the information of biohackers would be wonderful. Would love it. So the rigorous science and number 1 and 2, and the real evidence number 3, and then the combination, I think, will make the magic.
Yeah, I totally agree there. And yeah, I think we should, kind of talk after, because that's exactly what we're kind of doing at Rejuve, is making this, big international longevity research database where people, especially biohackers, can track their interventions, including the more adventurous people who might be, going to places like Roatan for experimental therapies and capturing that data and not letting it be lost. It was actually a subject of a recent talk I did last week at RadFest. And yeah, I think it's just super important, because if people are going to be doing this stuff and are already combining and trying these things, that we at least should be collecting the data and having a structured methodology to track what's happening, and to also get all of these clinics into one kind of network as well, to compare these insights and, help the AI to, kind of accelerate as well.
Absolutely.
I love it. I love it. Okay, last question, which we ask everybody that comes on here. What is your own personal goal for longevity? Is it to live forever? Do you want your brain implanted in a robot? Do you just want to extend your health span? How do you want this field to benefit you?
That I can walk the dog in silence. That's it. So that's it. I think I'm in the field not for personal reasons. I am in the field because I love biology. I love how the body is built. And if I can contribute to maintain the Picasso in us, that's what I want. It's not for my purpose. And for me personally, what my aim is if I am able to walk the dog at the beach or in the water, that does not matter, at stormy weather, I will be fine.
I love hearing everybody's answers, because everyone's are so different. Some people are like, "Oh no, robot for sure. That's what I want." And then mine is extend my health span. I want to be able to. I mean, I have 3 dogs, but I want to be able to walk them and have my kids and grandkids and still be able to do things and feel 35, 40, 45 when I'm 80, 90, 100, and so on and so forth. So love it. Jasmine, any final thoughts?
I guess I can, give my one there, which I've said before. It's like, I just want to be around to actually see how this all kind of plays out with all these advanced technologies that people are developing and theorizing about. Like, are we really going to have an AI singularity and like telepathic communication and, quantum internet and all that kind of thing? So definitely want to still be around to see the fruits of all of this emerge.
Yeah, maybe a final thought. I don't have kids. I never thought about it, actually. I feel very young, but I'm not. Anyway, so it's not for me to be for a very long time on Earth. But if I know that I left academic offspring behind, or scientific or healthy longevity offspring, so we do lots of talent incubators, really nurturing talent. That's it. Why should I be on Earth? I think nobody is waiting that I will be on Earth for 200 years. So let me grade myself down to just walk the dog and contribute now.
Well, we'd hope to have you around for 200 years if you would like to, and it's possible. So.
We'll appreciate it. I know we talked about this before, but we do have one of our, I'm not going to say our favorite employees, but one of our favorite employees is a talent from your incubator, and he's an exceptional longevity enthusiast, content writer, and so on and so forth. So do you, I guess this is the last thing. Can people just apply to be part of that? Or how do you go about encouraging people to join that if they're interested in it?
Yeah, so the Health and Longevity Talent Incubator is really our brand within our NUS Academy for Health and Longevity. So what we do very often is word by mouth. We have lots of participants who want to be part of that talent incubator. So it's a two-week boot camp on the NUS campus with fabulous mentors. So we're all staying together. We are hugely exhausted. It's a full program, and full means full, 24 hours, really full. and really merging our brains together, not in a computer, but having lots of ideas, lots of fun, and learning and building the next generation of leaders to make ourselves redundant in the end. So if you are interested, you should be young by heart. So it's really for a master, PhD, early postdoc, but it's independent of chronological age. That's very important. And then there's a huge selection process. So we have interviews with everybody. So half a year before the talent incubator, we are spending multiple weekends on Saturdays and Sundays and 15-minute slots to interview everybody, and then making the tough decision which 40 are being selected to come to Singapore in summer this year, and now we are recruiting for next year in 2026. So please, the enthusiastics, you don't have to have any background in longevity. It's very important that we are recruiting new talent into the field. It's about diversity. So we have from sexuologists to endocrinologists to IT specialists to entrepreneurs. We have everything included, because I think the magic is coming out of a group which are heterogeneous and who feel to be an outlier, but then after a couple of days don't feel to be an outlier, because we are merging together, and they have their peers afterwards in the alumni club.
I love it. Okay, I'll have to get the link from you, so if anybody wants to apply that's listening, they can do that. But thank you so much for being on here today. I feel like if I'm going to go to a longevity clinic, first of all, I've crossed all the other ones off the list, and now we'll only go to yours, because I feel like some of the ones we've not even talked to, but we've seen are like real woo-woo, just throwing stuff at you. And I want one based off of metrics and data. So that was my takeaway for today. I don't know if it should be or not, but it's been a pleasure, and we'll see you next time.